All right, welcome everyone. Welcome, welcome. Come on in. If you haven't dropped in the chat yet where you're from, we'd love to hear. It's super helpful. Kelly, hi, I just spoke with you. Mary from Texas, Michigan. And now you guys are going to put in your initials for your states and you're going to really test whether or not I know my own geography, which is really sad. Amazing, amazing. Well, I'm glad you guys are all here. I'm here with Brianna Holm from Headstart Health. Super excited to chat through Audit-Ready ABA. I realize not probably the most exciting conversation, but there's been a lot of talk of what's been going on right now in the field with the New York Times and with our Wall Street Journal. So I think this is a really important conversation for us to have. So welcome, everyone. I'm Dr. Sara Feldman. I'm the Director of Provider Engagement here at Headstart Health. And this is Brianna Holm. She is our Director of Operations here at Headstart Health. Today, we're excited to chat through Audit-Ready ABA, really talking about ethical documentation, supervision and compliance, and all of this era right now of OIG oversight. So OIG oversight is the Office of Inspector General, and we'll talk a little bit more about that. Like I mentioned, Brianna and I are both from Head Start Health, where we support BCBAs to go independent. We help them remove the barriers that keep them stuck. And something that's special and unique about what we do here is we are real BCBAs. We have created our own ABA companies before. We have helped lead large ABA companies, and we believe in opening up the playbook and sharing that. And I can't think of a time that's more important to get independent local ABA out there than right now. So, why are we having this conversation? Brianna, you've been reading the news. You send me all the free links from all your subscriptions. And so, what's going on right now?
Yeah, so, as folks know, ABA has evolved a lot throughout the years. We started as a intervention in a science that wasn't medically necessary. And as the law changed and we became a medically necessary service and we were following under all of the psychology departments, there became this push for clinical documentation for making sure that we were ready to be able to support all of the science that is happening on a day-to-day basis in these families' homes. So starting with treatment plans became a lot more rigorous, clinical documentation, but our field kind of stopped there. We didn't really evolve as much as a medical field typically does. And so now that we're growing so quickly, you're seeing a lot of Medicaid funding go through, even Medicaid rates increase. We're starting to get more attention as a field. We're starting to get attention from the broader medical community as well as Medicaid departments of just what is happening. Because we didn't have our own regulations as a board or as a science, there was unfortunately some behavior that was happening that doesn't align with the majority of our values on what ABA should look like. And so you're seeing this because there are cases and outlier instances of events that are occurring that make all of us raise an eyebrow of like, wow, that's not how a lot of our providers run their practice. Sara, you and I have talked about like, wow, we would
Yeah.
never imagine having a policy in place that had that behavior outlined or required
Right.
staff to do XYZ.
Yes.
But the problem is there's not current regulations in place to say like this is good or bad. So there are people that are doing that. And because that's happening, it's gaining headline news. There's just that article that came out over the weekend in the New York Times talking about naps and how people are billing for children to sleep, and they're making policies on how long someone can sleep within a 15-minute unit. And that is why we are starting to see more investigation. We're seeing more audits because unfortunately there are players that are making it so that none of us can be trusted anymore, and that we all have to be ready to stand up and defend what we have been doing and making sure that our systems and policies in place are actually aligning with what is best
Hmm.
for the individuals we serve. yeah, you're seeing the OIG audits across multiple states. You're seeing this even on the contracting and credentialing stage. So they're putting in more restrictions for people to get contracts. They're putting in more restrictions for people to get credentialed because they're trying to slow down the influx of providers to create some type of control in what's happening. You're
Yeah.
seeing Medicaid look at utilization at a really stringent level of like, okay, you're asking for this amount of hours, but you're only utilizing 15% of that. What is the story? What's happening? They're looking at school schedules, they're looking at things across the board that are barriers to what you're requesting to really challenge you to be like, are you requesting the right amount of hours that this individual will be able to utilize? Or is there something here we're missing? And that is something that you'll see and hear about as well. I mean, I've heard and talked to BCBAs where they're like, at my current company, it's a flat recommendation. Anyone under the chronological age of this gets this recommendation. Well, the more companies that are doing that versus the individualized care, the individualized development of a recommended hours is going to create the OIG, other, even other payers to create their own rules because they're realizing that as a overall, community, we don't have any. And so you're going to see this happen more until as a field we can take a stance of like, this is what good quality looks like, and this is how we expect all BCBAs and all ABA companies to create their policies, to create their treatment plans, their second documentation, so that we can all be on the same page of what good looks like. And so that's really why we're seeing this, is because as a field we're not aligned. Therefore, now OIG, other payers are coming in saying, okay, you all aren't telling us what good looks like, so we're going to tell you what good looks like, and we're going to put in some rules and regulations around.
Yeah. And I think what's really interesting is just the immense, like the huge, huge, huge increase of spend that has happened in the ABA field. And so you guys have a little um, bar chart here, but really, Indiana was that first, we saw the Wall Street Journal article about that, and really spending in 2017 was $21 million total for the entire state. And then when we were in 2023, it was over $400 million of what spending was for ABA services. There are a lot of factors that go into all of these. So it's not that all of it is fraud, waste, and abuse. It's the expansion, and expansion of Medicaid means that we have more access to ABA care, but it does mean that there is that opportunity for bad actors to be in there. And so I think that's kind of the through line we want to keep there. When you guys are done with this, I really want you to understand how you can become more clinically defensible in your documentation. Think about your operational vulnerabilities, figure out how we can improve our supervision practices. And then I just want you to feel more confident about what oversight needs to look like for your company, because not all ABAs, Pad, we know that. We love our local independent ABA practices, and we love the heart and the values that go around that. And it's up to us to show that there is really great high quality ABA that is happening and it's clinically defensible. But if it's not written down, it didn't happen. And so for us, that's really where we're going to start off there. So the OIG audits, and I'll give you kind of a little bit of background on that. So the OIG audits, it's the Office of Inspector General. Office of Inspector General comes from the DHS, so the Department of Health and Safety in our federal government. Our federal government's responsible for about 60% of the funding that goes to every state to fund Medicaid. So not just any ABA or just ABA Medicaid, but all Medicaid practices that happen. And so in that, we have a financial responsibility, a fiduciary responsibility to make sure that we take those funds from the federal government and we use them in the right way. The federal government does not define how ABA practices need to look, but instead they say it's up to the states to define what that looks like. But if you create a rule, states, then you must enforce it. So if you're saying that X has to happen across all sessions, then I need to know that you are applying it systematically across all people who are receiving those federal dollars. Or we'll take our federal dollars back. So the OIG is responsible for oversight of the state Medicaid. They are not necessarily responsible for the oversight of the actual individual providers that are here. Instead, that they're going to give guidance to the state Medicaid and say, state Medicaid, you guys took all of these federal dollars to fund ABA practices, but you provided no oversight for it. What gives? Maybe we would like to have our money back. And then in that point in time, it's not that the OIG is going to go to the providers to take the money back. They're going to take it back from the state, but the state is going to have a deficit then, and they're going to go back and do clawbacks with providers. The state is the person who is going to interact directly with providers. The OIG interacts directly with the state. And so when they were starting to do their investigations, really, we've seen it in Colorado, we've seen it in Indiana, across a multitude of other states. And what we know to be true is there was not a clear application of the rules that the state had created across all providers, specifically when it comes to post-billing audits. And so the post-billing audit is something that we do as a stopgap to say, hey, show me the medical documentation that justifies the spend that we gave you. So when we go to bill Medicaid, you're just sending in the billing form on there, but you're not actually sending in any documents until there's a post audit. In the event that there's not an audit, then spending can continue and continue and continue unchecked. So what the OIG found was there was a huge lack of clinical documentation. So things that were getting paid that didn't have any clinical documentation that goes along with it. There was lack of appropriate supervision of what was happening. So from the BCBA over the RBT. And so we'd have BCBAs with extra large caseloads, and there'd be no way that they truly could have seen all of these children. There were billing inconsistencies. And so those billing inconsistencies could look like there was time that was billed that there was no documentation to support. It could be billing inconsistencies of large either 24 hours of care in one day. It could be that it was for non-billable time. It could be for inflated costs. Really, there were a ton of different little minute things that go into that. There were people who were getting paid for kids receiving ABA services that had no autism diagnosis and nothing that could be found. We had some that had a high intensity of ABA services, but nothing to justify it. So a full 40 hours or more of care, and it went on for years and years and years, but nothing to justify it. And then services billed that didn't match like the treatment plan or clinical record. So it would be that they were working on a skill here and they would say that in the note, but there was nothing to justify it or show that there was a need in the treatment plan. So the reoccurring patterns were really what was something that flagged the OIG and said, hey, like what's going on? The OIG is looking for fraud, waste, and abuse. Abuse would be like, I know the rule, you've told me the rule, and I choose not to do it. Fraud would be that I know the rule and I'm going to go against it on purpose. I am going to leverage the system for my advantage, and I'm going to do it so in a knowing way. And then waste would be like, I am just not operating in a way that I am going back and checking in and seeing how's the spend going? Is it working well? Is this how we should be doing it? And so it's the combination of those three things that the OIG was looking at to see and to report back to the state to tell the state, hey, put some checks on what it is that we are doing here. So where risk starts, audits are going to happen. It's not if, it's when, and I'll keep saying that over and over. But audits start to show where we have some operational inconsistencies. And so it might be that if I'm a solo provider, I know in my head that all of these things are happening, but as I expand, they aren't. But really, we're starting to see in these audits a difference between like the billed hours and the clinical need. There was not the justification. Supervision expectations, so 5% for your RBTs, a minimum of 10% for the clients on your caseload, and then actual supervision. And then even from there, was the Supervision Act actually aligned with the CPT code and what it says and how it's supposed to be provided in our payer guidelines. There were gaps between treatment plans and session notes. So things being worked on in the session that did not align with the treatment plan having skills and goals that were never worked on in the session. Data collection and decision making was definitely not the priority of what was happening in the session. So we could see things like um, maybe adaptive living skills that were not medically justified in there, recreational skills, respite type things, academic things, all of those things are not happening. Or if we see that there is some data collection happening, there's not active thinking about what are we doing? Should we be changing this program? Should we be modifying it? And showing the way against all the different things you could be doing and why you chose to do it this way. And then we definitely see as you continue to grow that what you used to remember in your head is not what gets passed down, and that starts to show holes in our operational infrastructure. So, Brianna, to make this as applicable as possible for everyone, really, we put together some like scenarios. I'm going to kind of give you the scenario, Brianna. I want your reaction. We can kind of have a guided conversation with it. And then you guys in the chat too, feel free to chime in and we can fold those in as well. So this scenario is we have a learner who is receiving 40 hours of ABA. They've received 40 hours for 14 months consecutively. We have had a minimal reduction of intensity in the actual care. We continue to really stay at that high comprehensive ABA. We have very limited parent participation. So I'm going to say typically a few times every 6-month authorization. But it's more like 15-minute conversations. We're checking in, we're telling about data, but it's marked as parent training. Very modest progress. So not much deceleration of problem behavior, not much skill acquisition. And the goals have largely been unchanged. At this point, we've gone through 3 authorization cycles for this kiddo. So, first of all, Brianna, is this something that you've seen before? Am I pulling from fantasy, or is this something real? And you guys can chime in public chat. Have you seen this before?
Yeah, I think, this is a very common case of things that happen. Sometimes there are cases in which it's just the perfect storm of things that are happening. So you might have a learner who's acquiring skill at a slower rate. You might have a parent where they have a lot of barriers in their life that makes it difficult to do parent training. You definitely see you inherit a treatment plan from another company and you're like, these goals aren't matching what I'm observing, or maybe these goals are long-term goals. Like we see that a lot where we'll see like a terminal goal written in the treatment plan, but the learner where they're at is missing like 5 prerequisite skills to being able to demonstrate that skill. And so I think and you'll hear this as a repeatable recommendation, the first thing you always want to do is document everything and have a very strong documentation on what's happening in the day-to-day. And so I think that sometimes there's a gap in understanding the why behind a treatment plan. And so overall, when you see a learner like this where there's a lot going on and then you see the treatment plan and you recognize it's not actually the medical record that's telling the story of that learner of where they are and where we want them to get in the next authorization period, that's my first recommendation for anyone, is looking at what are the goals? What are the parent participation sections saying? What is happening in this treatment plan to be able to actually represent this learner and where they are and where we want them to get in the next short period? It's fine to have terminal goals in your treatment plan, but you should really have it outlined and sectioned off to what is going to be observable in the next 6 months. And so,
Yeah.
there isn't anything wrong with the scenario. It's how you respond to the scenario as the practitioner or the provider who has this individual on their caseload that makes it fall into the right or wrong category, if that makes sense.
Yeah, the devil's advocate in all of this could be that this kiddo or this client has really intense behavior,
Yes.
and we are working on decelerating problem behavior, but maybe they are 10 years old and they have a long learning history of this behavior. They've had minimal intervention up to this point, and there's some key things that we are trying to work on. And so modest progress in this, in the eyes of the auditor, looks like maybe only a handful of programs have been mastered. But what we know to be true about those handful of programs were they were beefy. They were
Mm-hmm.
hard. They were really intense. They've improved the quality of life for this family quite a bit. And maybe the limited parent participation, typically a few times per 6 months, maybe this is a single mom. Maybe this is someone who works two jobs. It takes everything that they have to be able to get them to a center or to have the ABA. And so, to your point, Brianna, exactly, there are things underneath that really help justify what it looks like on its head. And if it's not documented, it can't happen. In this situation, if you were going in as the auditor, Brianna, what do you feel like, what data would support continuing with ABA for this?
Yeah, I mean, I think it first and foremost is figuring out, okay, what is happening. I think you used the words correctly in the beginning. It's like we need to defend the hours. There needs to be clinical defensibility for what we're requesting. So if 40 hours is truly what is recommended for this individual, we need the assessment tools, we need the goals, and we need the clinical rationale on why 40 hours is recommended. 40 hours is a lot. And overall, we're seeing across states, across Medicaid requirements, 40 hours really being challenged of just like it can't be a blanket recommendation anymore. There needs to be justification for it. And so I always say like look at the where the learner is representing themselves in certain assessments and where they're scoring versus where we want them to get. What does that gap look like? But then also realistically as an auditor, they're going to look at what this client already has on their plate and can they feasibly have 40 hours of care. So you're
Mhm.
going to see them asking about a school schedule. You're going to see them asking about other therapies. They're not just asking that to get general information. They're getting that information so that they can say, okay, well, if they're in school from 8 to 3 and they have speech language pathology appointments twice a week and occupational therapy appointments twice a week, explain to me how you're going to get 40 hours in. And so they're not just asking these questions because they're quizzing you on how well you know your client. They're trying to figure out if your recommendation truly fits in there. And we've seen a ton of pushback from different states on that of like you are requesting this many hours but this is what their schedule says, help us understand the in between. So that's the first thing an auditor would look at this. And just to tie it back to the why, we care about the client making progress. We want to see the best environment for this individual to make the highest progress they can make. The auditor's looking at money. So every hour that you're requesting, you need to defend because they're looking at, okay, these are hours that we are going to have to pay for with this authorization period. And so you have to kind of keep that in mind when you're defending it. Yes, we care about the clinical expertise, they care about the money. Let's make sure that we're defensible in what we're requesting so that there isn't pushback in a way that we won't be able to get what we need clinically. And I know that there's a couple of providers on this call who have gone to appeals and really defended their clinical rationale to get overturned opinions from the state. And so sometimes you do have to go round robin with them for a little bit to truly get that.
Yeah. I think the thing too, though, is it's not about them trying to make it to be the least amount of money. It's to prevent waste
Yep.
because there's
Yep.
only a bucket of money that all individuals need to have, and they need to be able to say that from matter of fact that this amount of money is going to support this family to have higher quality of life and a less dependency on the social framework of all of this in the future.
Long
So
term. Yep.
yeah, are we going to have independent living? Are we going to have communication skills? Are we going to help decrease depression for the family and the family, needing additional resources and spending more money in that manner? So we're really thinking about like the whole unit here. And we're
Yeah.
thinking about, are we wasting money for a policy, or are we truly investing in what's going to create best outcomes? So you mentioned in this, though, you need this documentation, but what counts as documentation in this scenario? Where would it have to be in order for it to be defensible? Because I see Savannah in here talking about it's my favorite thing to do, but they won't take just any type of documentation.
Yeah, so they want a treatment plan that's defensible. They want clinical documentation to show. So, what I would say is like for the parent participation point, it should be documented every single time in a session or a session note or a clinical documentation, the attempts for parent training, maybe where you've modified it. So maybe mom can't join in the traditional sense of having parent training, but we can get creative. We could have her join for 15 minutes of a session and she's implementing some demands, or like if we're working on problem behavior, she's watching the RBT implement the BIP, and maybe she's even doing it sometimes with the RBT. So we need to make it very clear. We need to have this clinical documentation. And the clinical documentation, which we'll get into in a little bit, needs to be written as a medical record that shows what was happening and why. So always tying it back to the why. So this is what we're treating in this moment. These are the reasons why. And to your point, like if we are truly looking at long-term progress, so this is a skill that we want to be able to teach this individual so that we can reduce the likelihood they're going to be in residential, we're talking about that in the treatment plan. That is highlighted of these are the skills that we want to see observed so that they can continue to live in the least restrictive environment of their home with their caregivers right now. And so you have to have that in both the treatment plan and the clinical documentation in order to be defensible in what you're doing.
Yeah. Okay. I'm going to keep going because otherwise we could probably chat on this scenario. It feels very universal right now. But just to kind of reiterate those talking points of what you just said, strong documentation, it's a story. I come from a theater background. I think that there's a beginning, a middle, and an end that happens in every treatment plan. It is a narrative, it is a story. And your job as the writer of that story is to put yourself in the shoes of the reader and say, what information is it that they need in order to be able to gather all this data that I have and make the outcome that I would like them to have. So what do they need to know about the background history that's specific to this child? And so in your mind, you're thinking, well, this is just yet another thing. I have all this intake paperwork. I have all these different things, but putting in that detail into your treatment plan and to what Savannah is saying here, clinical documentation, it would be your SOAP notes, your treatment plan, the things that go into the medical file. And I'll talk more about what goes in that medical file. But generally, unless you're being audited, it's the treatment plan, and it's just the treatment plan, honestly, and that's all they get access to. And so really, you're thinking about this narrative. You need to put yourself in the shoes of the person who's reading it, and you need to think through, did I give them enough detail? Did I give them enough evidence to be able to make the leap from this? So I start with the beginning and then I tell them what the problem is, the inciting problem of what is happening and the treatment plan, what needs to be true. Why are they reaching out for ABA services? What is life like right now with ABA services? What is life if I don't intervene? What are the things that we can do? What can we solve? And then how will I know if I've accomplished that? And how will we slowly resolve the issue at the end, which is your titration plan out and your graduation plan? And that's really how we do it. And the story can change over time if necessary, but that's how we're guiding them through. We're teaching them the beginning, middle, and end of what happened in our ABA plan because they want to know that you have the plan, but they only have access to what's in front of them. So again, functional barriers that exist are super, super important to put in there. You're not calling anybody out. You're not saying that a parent's a bad parent for not being able to participate by saying they have a full-time job and they are not able to attend every single week, Magellan. They can't attend for an hour every single week, but they try. And here are the efforts that they show, and that we know that we have meaningful participation. And we're including that in there as well. So that's really where we're starting from. Another hot ticket thing that I saw, and this made me think of a lot of the legislation they're kind of fighting in North Carolina right now, which some of it I'm just, like, yeah, let's reform a bit. We have a BCBA. She has 18 learners on her caseload, multiple different counties and geographic locations. She provides mostly, I'm going to say 95% remote supervision. When you look at her schedule, you see overlapping supervision blocks, and we have very limited caregiver collaboration. So I've seen this before. Brianna, have we seen it before, or have you seen it?
Yeah, I mean,
Yeah,
unfortunately, we hear about scenarios like this pretty commonly, and we hear about this being a reason why BCBAs want to start their own practice. They want to do something different. They want to create an environment where this isn't happening. And I think that one thing that I'd like to say about auditing in general is auditing isn't a bad thing. If you're doing what you're supposed to be doing and you're providing good quality care and you have the documentation, an audit's actually pretty fun because you get to say, like, yeah, look at all this stuff I've done
right.
and I'm proud of the work I'm doing. When you put yourself in scenarios where you start to feel like, this doesn't feel right. So I'd imagine this BCBA is ending their day and they're saying, didn't feel great about my overlapping supervision blocks. Didn't feel great about being 95% remote today when there was big problem behavior happening and I haven't seen that client in person in over 2 months. There's this feeling inside of you that you start to recognize that maybe what is happening on a day-to-day basis isn't aligned with our standards as BCBAs. And so, yeah, this individual, I mean, just because you can put 18 learners on your schedule doesn't mean that that's something that you should always do. Do you feel like you're providing adequate care? Do you feel like, back to our first point, you're able to truly document and do all of the attempts and all of the assessments that's needed for all 18 learners? That's what my question typically is when people have a caseload. The multiple geographic location is a big one post-COVID. So we've seen this wave of telehealth BCBAs post-COVID who will be like, I'm a BCBA across the United States. And so, I'm all about telehealth for access to care for individuals who don't have BCBAs close to them in proximity, or when there's a case-specific rationale for it, or, there's a quick way for you to be able to support an RBT that you wouldn't be able to in home. But it starts to raise a red flag when it is one BCBA and they're licensed across all states and they're providing supervision across all states, and they've never seen those individuals in person, and maybe it's even in like a saturated market where there are in-person BCBAs that are available. It starts to raise a red flag for the state. You've seen states like Georgia create a law or a rule for their Medicaid that you have to be within a certain mileage to be able to be credentialed with the Medicaid. They're trying to defer from this multi-state BCBA. They're trying to defer from someone in Oregon being able to serve a client in Georgia Medicaid because they recognize that it's not always the highest quality care. They also recognize they have enough BCBAs in Georgia to be able to provide care right now. So they don't need BCBAs in other states. And so, these are areas where, to your point earlier, some of this stuff will actually help us as a field provide higher quality care. It doesn't mean that, any of these things individually or one-off is remotely wrong, but it's all together what we want to see on those 18 learners, probably not. The biggest red flag for me here, and something that we look at very regularly, is overlapping blocks of any kind. Anytime you have billing that you have one person in two places, you gotta raise a red flag. It's not going to fly. If it's not caught on your individual local level through your biller, which hopefully it is, hopefully they're doing an internal audit regularly and cleaning those claims to make sure before they push them out so that if there was a slight human error that it can be resolved. But if not, it's going to be caught on the state level and it's going to flag, and you likely, even if you have clinical documentation, you can't be in two places at once, so you're going to have to figure out a resolution there of paying back and retrieving some of that funds. And then the last one, the limited caregiver collaboration. I spoke a little bit about this last time. Something else I would just note is if you truly are running into a barrier with a parent and you've tried the, creative solutions of like, push into this session, or I can meet you in public, or I can do other community outings with you, and you've really tried to be super engaging, and you're still just not getting the buy-in from them. We know that exists. I've worked with families for buy-in as well, and as much as I wanted it, at that point, and Savannah, I think you asked like what other documentation, like keep a call log, like keep a very clear call
Hmm.
log of like, these are my attempts to reaching out to the family, these are my attempts to setting up parent training, and upload that to the file, the medical record, wherever you're keeping your medical record, and have that ready so that when they do push back and they say, hey, we're not going to give you an auth at all because you're not doing parent training, you can show. And hopefully you've had these conversations with the family, so it's not a surprise either when the family sees this in the treatment plan. But you want to be able to show what's happening across the board. The overall thing here is all of these things, except for the overlapping supervision watch, all of these things could be something that could be defensible. But again, if you don't have the explanation, you can't tell the story, you don't have the documentation, then it's going to be left up to interpretation. And as we all kind of probably see by looking at this doesn't interpret well. It doesn't look great for us as a field. And so that's where an auditor would be like, we need a double click here. I don't only want to see this BCBA's caseload, but I want to see every BCBA in this area's caseload, and I want to see if this is happening across the board. And that's how you go from a very acute, like small percentage audit to a full company audit pretty quickly.
Yeah. Yeah. I think the other thing that I want to kind of dive in on this one is just like we mentioned, just because you're allowed to have that amount of kids on your caseload, and there's not a rule that says from Medicaid or from your payer that you can't have X number of kids, it starts to dilute the quality of care. And that's also a huge issue that we run into of as a field. Yeah, you can jump in and provide an hour of what we say is supervision, but does it align with what the intent of the CPT code is? Are you thinking about what the what the progress is? Are you kind of weighing the different things? Are you poking and probing some different ideas of like, maybe this is a different strategy we should use, or here's how we're, have you documented all of that? But really, at the end of the day, when we're thinking about the whole unit of what ABA service delivery looks like, we know that supervision starts to help protect, and being actively there and having the time to do it protects program progress. We know that if we are actively looking at it at progress, and we are thinking about what the intent of the CPT code is, which is to modify, adjust, weigh, troubleshoot different things, we can prevent that stalled program progress of having someone work on the same thing for 2 months without it being changed. We can help decrease RBT burnout because we have identified a problem. We have worked on fidelity of implementation. We have coached through different things, and we don't have someone who's working in a silo over and over and over again, hoping to figure it out. We can help prevent low caregiver buy-in because we can spot things from the very beginning. And if, that buy-in is due to fatigue or it's due to outside barriers, okay, that's one thing, and we can really work on that. But it also might be because our treatment plan is lacking the so what factor on that. You're targeting a bunch of things that look like they're important because the VB map says so, but the parent does not care about that. They just want to be able to cross the street safely, or they want to be able to unload the dishwasher without having to worry about their child scaling furniture and pulling something down. And so you're having low caregiver buy-in this situation because you don't address the so what factor of your treatment plan and the social validity of all of it, which goes back to the intent of ABA, which is to improve the quality of life for not just the individual that we're supporting, but the whole family unit here. We also see documentation drift whenever we have just really packed supervision schedules because there's just not enough time. If every hour of the day is supposed to be quote unquote billable, there's no way that your documentation is up to date because documenting is not billable. And that's really frustrating as a field. And I get that. And there's so much that's the indirect service there. But There's only one code that allows for indirect care, and that's 97151, and it's provided under very specific circumstances. And so you're not able to provide that indirect care and update your documents. And then the last thing I'll point out here is that when we don't provide high quality supervision, that's when we start seeing staff and team members get creative, and they're implementing BIPs in different ways that you're like, that's definitely not what the intent was. Or you are not there to provide the support to teach how are we going to prevent the problem behavior before it happens, or how are we going to intervene when it starts, whenever we start having problem behavior in a safe manner. And that's when we start seeing staff injuries. So Samantha, I see your question. Explain what is and is not an acceptable use of 97151. 151 you can use for your assessments. What I'm saying is there's not a billable code for indirect writing your notes, going in and updating the goals when it comes to 97155 and 97156. And so if you have sessions from 9 o'clock to 5 o'clock and they're all billable, then you still have a ton of catch up time when it comes to writing notes, tweaking the treatment plan in the actual physical form, because the only thing that you can bill in a 97155 is actual modification of the treatment plan with the person that's happening there. It's not going back onto your computer and changing the goal. It's what the interaction looks like physically. So if you're doing it on the computer, but you're not actively interacting with your RBT or your client, it's not billable. And so I hope that clarifies. 97151, all I mean is, yes, you can use it for treatment plan writing. Yes, absolutely. If you have the authorization and you document what it is that you're doing, that's totally fine.
And one more point,
Good
sorry,
call.
Sara, going back to scenario two, one more thing that you'll see not only with this drift is you see RBTs get creative, but the thing that I see the most when I start to consult or talk about a case with someone and they haven't been in person is you see the procedural drift of RBTs training RBTs without a BCBA present to onboard a new RBT. And so, using the BIP as an example, you might have a really good RBT and you might have trained them on that BIP to like 95% treatment integrity, and you feel so strong. But then you haven't seen them in a month, and that 95 goes to 80, and then they train an RBT, and that new RBT is now doing it at like a 70, and then they have natural drift and they're at a 65, and then they train another RBT, and before you know it, your 95% treatment integrity BIP that you once had is now at like a 50%, and you had no idea because you haven't been out there in person. And what you can see through telehealth is that it's standing up. And so before you're making these decisions of telehealth versus in person, really think about like the treatment integrity and the fact that humans naturally have procedural drift with what we do on a day-to-day basis. And so you have to bake that into your training and your onboarding of new team members as well, because it's naturally going to happen.
Yeah. So, Mary, to your question, the CPT code is not written for you to update documentation. So, full stop, it's not written to do that. What your company and what your operational procedures allow for is called your organizational risk and your risk tolerance towards what the CPT code says and what the payer guidelines say, and what you're willing to risk in order to be able to have your day-to-day service. So I would say if I was designing from scratch, no. Updating the treatment plan and typing on your computer to tweak the different things, those are things that are not technically billable. Do I see it happen every single day? Yes. Same thing goes with session note writing. Session note writing for your RBTs is not a billable action. It is not something that is written in our current CPT code to allow for that. And you can go on to the Coding Coalition and look at what that is. Do I see people use the last 7 minutes of their practice every time to do that? Percent. Should you? I'd say if you're going to go with the CPT codes, I wouldn't. And so again, that's where we see drift too of the operational procedures of the company have shaped the interpretation of the CPT code in order to maximize for billing time and to make it easier to navigate the day. But would it be a big inconvenience to stop everything and make sure that you have build time, or not build time, but non-billable time for everyone to work on their paperwork? 100%. So that becomes really tricky there. Kelly, if you have a big picture question, yeah, definitely throw it out. We're probably not going to get through all of our scenarios here, and that's totally fine. And so I'll talk through this scenario quickly. Is we see this a lot of client tolerated session, worked on goals, no major behaviors, see the trial behavior, trial and behavior data attached. So this not clinically defensible. When you get audited, they take your session notes and they want to see your session notes in there, but otherwise they wouldn't have access to your session notes because they don't go magically over to the billing department at the insurance company. But see trial data and behavior attached. Raw data does not defend what actually happened within the session. Those are things that are not going to be looked at or interpreted. You can use them to supplement your note, but you must always have narrative form that goes along with it. And you must show actual behavior analytic techniques that were used in addressing that. And so here we'll kind of talk through. Brianna, I hear a lot of conversations recently about this idea of real life start and stop times of sessions. It's definitely a really tricky thing because people say, well, the session was supposed to be, it's billable from 12 to 2. So I marked it as 12 to 2. But if you start at 12 and you end at 2 and then you pick up your next kid at 2, it's physically impossible for you to be able to do that. And so more that's a scheduling note, but that's not an actual start and stop time of the session. So what should they be doing instead?
Yeah, and this is where I will say technology has helped us immensely, especially with clinic based services where you do have the back to back. You want the accurate start and stop time. Another thing is kind of going back to schedules for clients. Auditors across payers are human and they know that humans are providing these services. Therefore, it is nearly impossible for one provider to 100% of the time be like a 9 to noon every day. Life happens, it might take a moment to get to where you need to be. That needs to be represented in the documentation. And so you should really see on the clinical documentation, like if it's a 9 to 12, maybe it's a 9:03 to 11:58. Maybe it's a 5 to a 12:05. We should see that accurate clock in and clock out because it allows for just a real life picture of what's happening on a day to day versus this scheduled or this goal that we have, right? Our goal is from 9 to 12. The reality is it's probably you're knocking at the door at 9 o'clock. You're clocking in and starting your data at 9:04. And so you really want to make sure that that's accurate because if they are seeing that you're billing, so not the schedule, not what's on your schedule, but the claim that's going out to the payer, if the claim is the same exact time every single day and it has even with one client, maybe one client has 9 to 12 with one therapist and then 12 to 3 and they see that all the time, they're going to look into that. They're going to see what's happening and making sure that you have the actual time on your clinical documentation to represent that. That's not to say that if your RBT is there to start session at 9 o'clock and they're actually ready to, they should wait until 9:01 because they're nervous. No, if they can actually clock in and start their data collection, please, by all means. But let's make sure that we're not just using the scheduled time to go out on our claims and we're using the actual time that we've been taking data to submit the claim.
Yeah, they're looking for real life variability. Kids fall asleep. Did you mark it as non-billable time? Did you indicate that in your session note? Kids eat lunch. I don't have any life skills goals that are in my treatment plan for eating lunch. Did you pause? Did you do that? So there are things that happen that are regular interruptions that they want to see real life reflected in that note, because otherwise it's assuming that you are maximizing everything for financial gain. And that's just not the case. And that's not what I see the intent of our independent owners doing. But a lot of those things are just one more step. It's a procedural step that we just need to make sure that we embed into our training. The other things that we're noting here are clinical narratives that are linked to behavior analytic skills. And so we need to use behavior analytic language that goes into that. And so one way that we've kind of worked with that is we know that when we're supporting RBTs, sometimes our notes can be a bit off the wall or unexpected, and it's really hard to make sure that we're looking at every single one on there. That's okay. And so we need to make sure that our notes are structured in a way that we are picking the behavior analytic strategies that are present and that they are put into a sentence form, and that we have the goals that we are addressing and making sure that those are also put into sentence form. And then for you BCBAs who have all the training and all of this, that you're using behavior analytic language to talk about your decision making. Even if the decision was to stay the course, what did you consider? What were the things that you weighed? Why? What were the pros and cons? All of those need to go into your session notes to make sure that we can justify the code, even if you chose to keep everything exactly the same. Okay, so we'll go ahead and skip over on scenario 4, but you guys will get this access when we send this out. I want to leave you guys with things that you can know for today. So payer guidelines are your responsibility to know. And so even if you are working for not working for yourself, you're working for a larger organization, if your CAQH and your license is being used, then you need to know what the payer guidelines are and know what's acceptable and not acceptable. Because at the end of the day, the Wall Street Journal, the OIG, the New York Times, they're here and they're looking at the actual individual practitioners as well. And so if you are perpetuating inappropriate use, then you will be a target for an audit as well. You need to know what the CPT codes are, what their descriptions are, and their intended purpose. And just because there's been operational drift of what that interpretation looks like within your organization, that doesn't mean it's okay for you to continue. And you need to know that. We have to document everything. If it's not written down, it did not happen. But on the flip side, if it is written down, it did happen, and it needs to be medically necessary and tied to the treatment plan, because that is what you got permission to use those dollars for. And so you must show that you have continuity of that as well. We need to measure documentation fidelity. And so how we write things, the same way we measure treatment fidelity. And I'll pretend like I know that all of you guys are doing treatment fidelity and everything is great, but we need to measure that in the same manner. And then really finding a self-audit cadence that gives you an opportunity to go back and look at session notes, look at treatment plans, review payer guidelines, make sure that I feel really good about all of that as well. So if you were to get audited, here are the things that will get audited. They ask for the medical file, essentially, for a child or an individual, and they'll say, here are 10 random kids, and I want 3 months. And for this client, I want from February to April, and it's for this year. So give me all the session notes, the treatment plan, the progress, and everything that needs to be in that file. So what is the file? The file is all your intake documentation. So your intake packet, your consents, your care coordination, so efforts to reach out to the SLP, the OT, the doctor to say, hey, I tried to coordinate care. I want to make sure we're all on the same page. Your autism diagnosis, making sure that it's accurate. If you're in the state of North Carolina, do you have your service order likely is what is also going to be added into that. And then sometimes you need that letter of medical necessity. So that's one part of your intake documentation. On your treatment plan, they're looking for the evidence of individualization. So you don't see other people's names, the wrong pronouns, things that seem like fill in the blank. They're looking for signatures and making sure that the family consented and that they have reviewed that treatment plan. They're looking for documentation of progress, that it's tied to the autism diagnosis, and that it meets all the payer requirements that are specific to what their treatment plans need to look like. They're also going to look at staff files. They want to know that your staff have background checks per the payer guidelines. They're going to want to know that you have I-9 documentation in there, evidence of RBT certifications, that you have provided training. And so the payer guidelines will say, what kind of training you need, or maybe they won't. Sometimes the state says what type of training they need. So HIPAA, bloodborne pathogens for child abuse and mandated reporter, things like that. All of those should be in there as well. And then credentialing for some states when that's applicable. They'll look at all of the session notes from that time period. So they'll want an individualized narrative format with the real start and stop times, use of ABA techniques tied to the treatment plan. They're looking for signatures from your RBT and that they were timestamped within 24 hours of it happening. And I know that that'll cause a scurry. There's usually not a rule that says how long it needs to be written, but it is something that you need to make sure that the signature and the note are within a very justifiable time period and that it meets the payer requirements. Every payer has different requirements. Some have zero requirements, but say write a session note. And so we're going to go with the best practices there. The final part is they'll ask for all of the billing that goes out with it. And so your biller can help you with that. They want to know that you followed payer standards, that it's been rendered accurately, and that you have the accurate rendering provider on there. So it's the person who is credentialed, who is actually providing the service. It's not some BCBA that's down the street that no longer works here that had their name in there and happens to be the authorized provider. They want to make sure that it matches the notes match the treatment plan. And so the time, the start and stop times that go along with that, the correct units and billing standards that are on there as well. This is just a glimpse of it, but when I say the medical record, this is what it is. And so if you don't know if you have all of these things, especially those staff documentation ones or your intake documentation or things like that, this is a good reminder to make sure it's all in one place and that it is accessible. Okay, so we've come up on time here. This has been a really great conversation. Really, I want you guys to kind of lead with this idea of when you are ready for your audit, we are able to be able to defend really accountable care and that we are improving the state of ABA. It is not that all practitioners are doing the wrong thing. It's that all practitioners need to be documenting what it is that they're doing. And so that's what you guys are doing here. We want to be able to show measurable progress. We want to be able to say that there has been meaningful supervision. We have clear clinical reasoning that we can prove ABA is the reason why this child is making great progress and that the documentation is defensible. It doesn't give you question marks when you look at it. And we know that a lot of independent BCBA owned organizations are going to be the next generation of what really takes the lead here because we have seen what it looks like from a large organization standpoint. We've seen the organizational drift that happens and we see the heart and the values of what happens with independent BCBAs. And so this is really, I think, the next field. I'm incredibly biased as a 10-year entrepreneur, and Brianna is too. And so that's an opinion, but I feel like that's the group. That's the grassroots group there. So for those that might have questions, and I see Kelly's question, I think it's an important one. I actually think this would be a really great CEU there as well.
Yeah, I was going to say the exact same thing. I think, Kelly, this is a broader question of like, okay, there are more and more regulations and rules coming out from states, from payers. How do we operate ethically, train our staff ethically to be able to do this? I guarantee everyone on this call has had an RBT say, well, that's not how I did it at my old company, or that's not the way that we did it previously. We've always, let the kid nap for 30 minutes during the session. And so you are having to take learned history and reform it a little bit. And so I think that your question is an important one, and I want to make sure we give it the time. I think another CEU that of talking about, okay, these are the rules. This is how you can set up the systems. This is how you can set up your company policies to make sure you're following them, but also aligning with our ethical obligation as BCBAs.
Yeah. And then I think also figuring out ways to truly incentivize RBTs to work for these local independent ABA organizations in which we might have lower billing time, but they are still having meaningful employment as well. And so I think that's a really great call out, Kelly. All right. So for your CEU, go ahead and scan this. If you don't have time to scan it, that's totally fine. we will email you out this recap with this video and the PowerPoint here, and you'll have access to the link for your CEU as well. You'll get your CEU within about a week or so. If you don't hear back from us, you can always email Sara at headstart.health, and I'm happy to grab that for you as well. And then Monique has also put that link there as well. If you have any questions, you guys feel free to put them in the chat. We can kind of stick around for a few more minutes. Otherwise, thank you so much for attending. Definitely a jam-packed conversation with really great stuff. I feel like maybe this might be a continuing CEU at some point as well. Thank you guys. Awesome. Okay, you guys, a lot of Samantha's on this call. Very good. All right. Well, we'll go ahead and end it there. If you've got questions, feel free to email us.